Hi there, my name is Sarah and this is Nikki. We're both physiotherapists working in the respiratory team, and our research has looked at the factors that influence the completion rate of pulmonary rehab here at Counties Manukau. Just to provide a bit of background into this, pulmonary rehab is a comprehensive multidisciplinary program which is designed for people living with a chronic respiratory condition. It's been well researched and proven. Strong evidence has proved its efficacy, that it will improve your health-related quality of life, reduces people's shortness of breath, reduces mortality rates, and can be associated with a reduction in hospital readmission rates. It has been recommended in all best practice guidelines, and the program has been shown to be cost effective, and I can refer to Jeff's previous slide that he showed with the London Respiratory Group's COPD value pyramid that showed that after flu vaccinations and smoking cessation, that pulmonary rehab was the next most cost-effective intervention for COPD. But despite the fact that there's this huge amount of evidence to prove it's effective, uptake and completion rates, both here at Counties and worldwide, have been shown to be really poor. One of the things to bear in mind is that most pulmonary rehab programs are 8 weeks in duration, and participants are required to attend twice per week, so that's 16 sessions. So it is quite a big commitment for people. So attendance and completion rates have been documented already in the literature. In a systematic review by Keating, they said of all the people that were referred to pulmonary rehab in the studies that they looked at, nearly half of those people never attended a single appointment. Of those that started pulmonary rehab, the dropout rate was just over a third, so really high. William Levac has done a study here in New Zealand in 2009. At that time, he estimated the COPD population to be about 270,000 people. And we can see that less than 1% of the population was referred to a pulmonary rehab program, and that actually 0.5% of those people actually completed pulmonary rehab. So this is thought to be one of the most effective interventions for COPD, and yet we're only seeing such a small number of people. Some of the reasons have been looked at already in the literature, and one of the strong themes that comes through is always transport, people having difficulty accessing transport to these programs, having to travel a long distance, and parking is always an issue. And another theme that seemed to come through strongly in the literature was exacerbations of either their primary respiratory condition or one of their comorbidities. So here at Counties Manukau, we've done a lot over the last 5 years to try and make our program better, sooner and more convenient by taking it out into the community where it's within people's backyard, it's closer to home, to overcome that barrier of transport and travel. And yet this snapshot of data showed that our referral rates and our uptake is still really low. So we needed to dig a little bit deeper and find out some of the reasons.
So then, knowing what we know about the rates of completion in our pulmonary rehab program, we decided that we needed to find out or identify the people who don't complete our program and find out a little bit more about them. So the aims of this study were to find out and describe the characteristics of people who don't complete the Better Breathing pulmonary rehab program at Counties, and to identify the predictors of completion of our program. So what we did was we collected information on patients who were enrolled in our program over 6 years from 2010 to 2015. And we split them into 2 groups. So the first group completed the program. Those are people that we defined had come to, or completion was defined as at least or more than 75% of sessions were attended. And the other group were the non-completers. So those people who came to at least 1 session, but then dropped out before they attended that 75% cut-off rate. Cut-off level. So we collected demographic characteristics on these people and some clinical outcomes, and we pulled that out of PIMS, and then any missing data was identified on using Concerto. So we ran some statistical analyses to identify the differences between the groups and to identify the predictors of completion. The outcomes that we collected, some of them we chose to collect because they're factors that have been looked at in previous literature and found to be important. So, for example, marital status and the distance from home to the pulmonary rehab site. Other factors we thought were particularly important for our population. So we were really interested in finding out about ethnicity and the language spoken by our patients. And we also were able to collect all the clinical outcomes that you can see here. These are routinely collected in our program anyway, so we've run statistical analyses on all of those too. So we collected information on 1,695 patients, and I'll draw your eye to a few things here. So marital status, first of all, you can see there's a larger proportion of married participants in the completers group than the non-completers group. And you can also see that there's a larger proportion of single and divorced participants in the non-completers group as compared to the completers group. Now this is in line with previous literature showing that married participants are more likely to complete the program, presumably because they have higher familial support levels. One thing that we think is probably more important in our population is identifying whether people live alone or not, because of course many Māori and Pacifica families might have a large family unit at home, and whether they're married or not perhaps isn't such an important factor. So that'd be something that we'd like to think about in the future. You'll see here that the distance from home to pulmonary rehab actually is a non-significant finding. So we think that the reason for that is that we've made a big effort to take our program out to the community. So we think that the distance between the patient's home and the pulmonary rehab site is not such an issue anymore, which is really good. Language, here you can see that there's a larger proportion of patients who speak languages other than English in the non-completers group compared to the completers group. And this probably stacks up with our findings on ethnicity, which we think is the most important finding from our study. So you'll see here that in the completers pie here, there's a much larger proportion of Europeans, so that's that red section, compared to the non-completers group. You'll also see that in the non-completers group, there's much larger proportions of Pacifica and Māori people as compared to the completers group. Also, we ran some logistic regression analyses and identified some predictors of completion. And again, I'll draw you to the most important predictor, we think, which is ethnicity. So where Europeans are used as the reference, Pacifica people are 40% less likely to complete our program, and Māori people are less than half as likely to complete our program compared to European participants. So we know that Māori and Pacifica people do poorly in the New Zealand healthcare system. We can see that from countless healthcare statistics that have been talked about today as well. And that is the same in respiratory disease as well. We know that Māori and Pacifica people smoke more than non-Māori, non-Pacifica people. The prevalence of COPD in Māori people is twice that of non-Māori. Māori and Pacifica people are much more likely to be hospitalised and die from COPD. So what we can see here is that the people who would benefit the most from pulmonary rehab are the people who are not completing our program. So we think that it's really important, of course, that we reduce that gap in healthcare between Māori and Pacifica people and Pākehā people. So in our program, we need to strive to engage Māori and Pacifica people in our program in order to reduce healthcare inequalities and improve health equity. So now that we know that Māori and Pacifica people are so at risk of dropping out of our program, we need to find out why.
So the next phase of our research is undertaking some qualitative research, which we received funding for from the Tupu Fund and have received ethics approval. And we've got two cohorts, 10 Māori participants and 10 Pacific participants. And we're carrying out semi-structured interviews in their own homes. That data has been collected and we're currently doing the thematic analysis of that data. So we hope to present that to you at next year's Research Week.